if I was starting it all again, what would I do differently? Well, I'd get someone really smart like Kate. That was one of the biggest things, one of my best assets at the time. I really have to thank her. The number of times we almost gave up. You have to be really resilient in this job, but she stuck at it, and so did the team around her. So I wouldn't change that. But there's much. We made every mistake in the book, and there's much that I would change. And now that I have a different view in terms of being an executive leader or now a chief executive, I would do some things differently. So I thought I might talk about that for the next little while. But I am a clinician, but executive people, we're seen as bureaucrats, bean counters, and when they really want to piss you off, they call you an administrator. So I've got a plastic surgeon who comes and says, I spoke to the administrator, when he really wants to piss me off. In Western Australia, we haven't been doing it for 21 years like the Victorians. A case mix funding model, ABF, activity-based funding, relatively new in Western Australia. And so much of our redesign was about fending off resource grabbing. And we need more of this, and we just need more funds, and we just need more beds. I tell you what, you do not want more beds, you want less. And I'm closing beds wherever I can see beds that can be closed, or maybe even half closed. And there's a lot of someone's gotta. Who's gonna? But you need to turn that round into I'm going to. But we have clinicians, and I'm really talking. I'm aiming this slide at doctors. Let's just be, let's be plain about it. We do have, a workforce that is passionate about delivering good outcomes. But interestingly, there are variations in understanding around what patient safety, quality, and risk are. And we certainly have excellence in our hospitals, and you've all got it too. You've got highly performing teams that are true teams, not pseudo teams. I'll talk about Michael West's concepts in a minute. So you need to find those examples of excellence and broaden them around. By the same token, or the flip side, we all have to think about the quality catastrophes, the embarrassments that have occurred around the world. The Mid-Staffordshire, Francis report, Garling, Douglas. There are a number of things you can read. The messages are all the same. I was a head of an emergency department. I'm doing redesign, and Kate and I have got a team, and we're running around trying to get people to think of new ways of doing things and come and map things and create solutions. And yet, on a day-to-day basis, we're starting to ask ourselves, who's running this hospital? Who's in charge? You've got this incredibly complex and intricate machine that somehow seems to just chug along and operate. And yet, a lot of the time, it seems as if it's completely not being run at all. By the same token, I mean, we've got a hospital leader system, or a ED thing that codes people in colours in terms of length of stay. Whose job is it? Back then, it didn't seem to be anyone's job to worry about the red. And whether that was elective surgery or ED length of stay or outlying rates, whose job was it? And everyone seemed to be doing this and going, oh no, it's not my job. And late starts in theatre and cancellations. Whose job was it to worry about the red or be anxious about it? And were they anxious about it? They didn't seem to be. Everything seemed to be pretty calm. I'm very comfortable being over here today talking because I know I've now got a really highly committed people who are running around worried about the red. And they're saying, for goodness sake, we've got to fix this before Frank finds out about it. And that really makes me feel fantastic. And it's not because I'm scary, it's just because that's the way it should be. What data are you using, or were we using, to run the hospital on an hourly, daily, weekly or even monthly basis? We had oodles of data, and yet no one seemed to have any information at all about what was going on. And it didn't seem to have, data didn't seem to be used very much to make decisions. We seemed to go with eminence and dogma rather than data. We have a lot of bed managers, but who's managing the beds? High outlying rates, and there's a robust literature shows that patients who are outlying have longer length of stay, a worse patient experience, higher 30-day mortality, and higher 28-day readmission rates. I've got a whole literature review on that I could show you. So, you know, bed managers, despite their best intentions, tend to create outliers because they're worried about putting people into beds as quickly as possible. And they want you to meet the need. So they tend to put people into the next available parking spot, which might not be their home ward. If things aren't going well, or you've got a problems, is there a standard operating procedure to escalate? We would come in on a Monday and find 30 patients in the ED and hear that everything had just gone to hell in a handbasket over the weekend, and say, well, you know, who did you call? You know, what did you do? Oh, you know, coped, you know, got there in the end. But, you know, no real escalation or assistance. Does everybody in your hospital know what your mortality rate is, your hand hygiene rate, your falls rate? Do they care? Is it reported? Is it on an electronic screen on the wall outside the cafe? How are we measuring and managing length of stay? And variation in practice, this is a big theme. Variation in practice is associated with poorer quality and higher cost. There's a literature about that. So how are you identifying variation in practice? It might be how you do total knee replacements. It might be how you approach stroke, whatever. How you do patient blood management, whatever. How are you identifying variation in practice and standardising everything you possibly can? Because when you standardise the way something's done or pathways, you improve quality, improve experience, you decrease cost, and you make yourself more efficient. So having systems in place to find variation in practice, I think, is quite important. We didn't have any of that. And in fact, we seem to have a culture which seemed to actually resist this kind of thing. In fact, we had managers whose job it was to keep the status quo rather than leaders who were trying to improve things.